Well, thank you. We appreciate the opportunity to talk with you about the new model, and we thought we'd just start out with a really brief overview of the background on the Cost Review Commission and background on rate regulation in Maryland. I know some of you are new to the process and wanted to just start with that. The Health Services Cost Review Commission oversees hospital rate regulation in Maryland, and it has an independent 7-member commission, similar to a commission that MHCC has, similar to MHCC, decisions are appealable to the courts. Our commission has a balanced membership, and by that I mean it's made up of payers, providers, physicians, and policy experts. And that composition changes from time to time, but that is generally a mixture of folks who are on the commission right now. We have a very experienced staff of about 37 folks. Lots of them are IT and data analytics folks, because we deal with a great deal of data during our regulatory process. Our commission has broad statutory authority over rate setting in hospitals, which has allowed us to evolve over time in the models that we have. The commission has lasted for many, many years because it has had broad support from both from hospitals as well as payers and other stakeholders. The rate setting that HSCRC does is all-payer rate setting. It is the only all-payer rate setting model that is in existence in the country today. We do that under a Medicare waiver that was first granted in 1977, and that waiver was renewed under a different approach, the one that we're going to talk about today, in 2014. And that allows HSCRC to set hospital rates for Medicare. And that's really an exception that today is not existent in any other state. Secondly, the all-payer rates apply to Medicaid, and that's a requirement of the model, the waiver model. And lastly, state law requires health insurers, managed care organizations, and others to pay HSCRC rates. Under the rate setting model, what has really made it work is that all payers pay their fair share of full financial requirements, and importantly, some social costs such as uncompensated care and physician and other medical education costs. And this process has limited cost shifting across payers, the cost shifting that is existent in other parts of the country, and has allowed a very low markup relatively over cost in Maryland compared to prices in other parts of the country. This has been very valuable to patients, the state, and the hospitals. And as we approach the process of the new hospital model, we found that the advantage of having this waiver from money coming into the state from the federal government was that more than $1 billion of funds were coming into the state that we otherwise wouldn't get if we didn't have this waiver and if hospitals were under the prospective payment system that is in place in other states. So that takes us through a little bit of history of rate setting, and now we're going to focus on the new all-payer model. We are implementing actively implementing the new all-payer model for hospital payment that was approved effective January 1, and that was approved for a 5-year time frame, as Ben mentioned earlier. And the new model focuses on a new approach to rate regulation. The old model focused on the cost per admission. And as the state began to develop early approaches to healthcare reform, we started to see the cost per admission rise. So it put our old waiver in jeopardy, and we focused on, in the new model, we're focused on not just a Medicare test, but an all-payer test. We're focused on total hospital payment per capita, so not just inpatient per admission, but inpatient and outpatient hospital payments per capita. And a shift to focus on population health and delivery system redesign. At the end of 2016, we're slated to file an application to extend the model to focus on the total cost of care in year 6 and beyond. Some brief highlights of the new model. The key requirements of the new model are to limit the total hospital per capita revenue growth to 3.58% annual growth per capita, and that could be changed in year 4 and 5 of the model, depending on the changes in the per capita Maryland state product. So effectively, that 3.58% growth rate was based on a 10-year smoothed average of economic growth in the state of Maryland. And so the concept is to tie hospital cost growth to the growth in the Maryland economy. The second requirement is, so that's how savings will be generated for the all payers. The second area of savings requirement is for Medicare in particular, and that requirement is based on generating a savings of $330 million over 5 years. That's compared to a dynamic national trend. So effectively, in order to achieve that savings, we have to have our payments for Medicare beneficiaries increase at about 0.5% below the national average. The third requirement, so the old waiver just talked about finances. The new waiver is really focused on quality improvement and patient-centered measures, and in particular, we have a requirement to reduce the Medicare readmissions in Maryland down to the national average, a 30% reduction in hospital-acquired conditions under the MHAC program over a 5-year period. And there are many other quality improvement targets that are being measured and monitored in connection with the new model. So this new model is really shifting the focus of of effort to improve health, improve outcomes, and control costs for the benefit of the patients. And the approach is for hospitals to gain control of their revenue budgets, and we'll talk a little bit more about that, and focus on providing the right services and reducing utilization that can be avoided with better care. So the focus of the new model is on the triple aim, and the execution of that model really creates a new context for the Health Services Cost Review Commission, historically focused specifically on rate setting and some value-based payment approaches, but now shifting the focus of the Health Services Cost Review Commission to ensure that the payment methodologies that we're creating align with the new ways of organizing and providing care, both inside of the hospital and in other provider settings. And a continuing focus on the total cost of care and containing growth in the total cost of care of the hospital, and evolving our value-based payments around efficiency, health, and outcomes to tie into the triple aim that we're focusing on. For year one, we were very successful in meeting our year one goals. We had broad public engagement in the initial implementation with over 100 individuals involved in that process, and the individuals were a broad spectrum, not just our typical providers and payers, but also physicians on every work group, nurses, consumers, and our fellow agency staff were very heavily involved in the process. So Ben Stephan attended many of our work group meetings as well as other staff members. All Maryland hospitals went on global budgets during the initial year. More than 95% of hospital revenues are now under global budgets. In brief, global budgets create a fixed revenue base for a 12-month period with annual adjustments. With that process, hospitals are able to retain revenue when they reduce volume. So if they reduce volumes for potentially avoidable utilization, then they can keep the money and invest the savings in more care improvement. So that's essentially the major benefit of the global budgets, is to create a stable revenue base to allow the care delivery system to change. There are other updates to the global budgets, including annual update factors, quality adjustments, and also we've been focused on developing an approach to move money when patients shift across hospitals. So effectively allowing the money to follow the patient if patients go from hospital A and they end up at hospital B, that we have an approach to move money. So that's a different reduction in volume than potentially avoidable utilization, which isn't in the hospital system at all if the patient goes to another hospital. So essentially, what we're doing with the global budget system is moving away from a volume-driven payment methodology that was, up to this point, based on units and cases times volume would drive the hospital's revenue. And under the new model, the revenue is set at the beginning of the year, so the hospital knows what its revenue is. And the revenues are updated for inflation trends, for changes in the population, and for the value modifiers or the quality payments. And that creates the revenue budget that the hospital knows at the beginning of the year. As volumes change in the hospital still bills individual patients based on their service level, and the hospital raises or lowers its rates depending on its actual volumes to stay on that global budget to produce the revenue. So if the volumes go up, the hospital lowers its rates. If the volumes go down, the hospital raises its rate, and that's how they stay on their global budgets. From a specific requirements perspective, we reviewed the specific requirements. For the calendar year 2014, hospitals were well under the all-payer limit with 1.47 per capita increase. We have been getting data from Medicare. We haven't completed our audits, but subject to audit, the Medicare data is showing us that we're on track with the savings requirements. Our quality improvement activities are ahead of where we were projected to be. We have a 30% required increase over 5 years, but in year one we had a 26% increase. So we are almost there with those requirements. The one area where we did not make as much progress as we wanted is in readmissions. They are down, but we need more progress to reach the national average at the end of 5 years. During that process, the hospital performance also improved, and overall there was increased profitability in hospitals compared with the prior year. It's also important to note that hospitals did actually do a really good job of keeping volumes level, and what we've found at the end of the calendar year is that volumes were flat except for the growth related to the new Medicaid enrollees. And the new Medicaid enrollees added some growth, but a lot of that was pent-up demand, and that has already tamped down and receded. I wanted to talk briefly about how we're approaching implementation and the processes that we're in now. Many of them are very involved with the staff of MHCC in terms of what we're doing right now. In the first year, as you heard, we were very focused on getting hospitals on global budgets, meeting the test measures that we had to meet under the new model, developing our monitoring infrastructure, and developing concepts and making data available about potentially avoidable utilization. And we've been very proactive in distributing monthly data to hospitals on potentially avoidable utilization, and also the stakeholder input process that we already described. In year 2 focus, we are now focused on areas of clinical improvement and payment alignment, and all of those activities are being conducted in a partnership approach with other state agencies as well as stakeholders. So the aim of what we're trying to drive forward is an increased focus on chronic care, care coordination, as well as better episodes of care in the hospitals. We're also focused on payment alignment, and in particular, things that we're focused on are the new Medicare chronic fee and how can we drive that process forward in Maryland to have our physicians get access to those funds, because they'll help drive forward the process that are needed for better chronic care. We also note that Medicare is very willing to engage in additional innovations with the Maryland model at this time, and we expect conversations to start heating up, if you will, around that topic. We are also beginning conversations with Medicare and filing an application to add some gain sharing and pay-for-performance waivers to our existing model. They weren't included in the initial model, but now that all hospitals are on global budgets and some concepts have been developed that we're moving forward with now. Finally, we're also focused on continuing discussions with Medicaid, who is focused on developing a dual-eligible ACO approach and on integrated networks for patients who are not already in an ACO or a managed care plan with Medicare. In year 3, we would be focused on implementation of these activities. This is a lot of infrastructure that needs to be implemented to scale up the model and to make it sustainable, and also to continue the focus and expand the focus on patient engagement and consumer engagement in the process. And we've had active work of both the HSCRC staff and the MHCC staff with the consumer work groups. And also to focus on additional alignment opportunities as we move toward the application process that needs to take place for the extension beyond year 5. And just to give you a picture of what we're how we're organizing these activities, the HSCRC set up an advisory council to give it input as the new model began, and we check in with them periodically. We have ongoing HSCRC functions that are really part of our statutory functions, and that is ongoing development of payment models under the new approach, and also focus on developing performance improvement and measurement and value-based purchasing models, if you will, that go along with our payment models. But as we just spoke, a lot of what we're focused on right now are what we're describing as partnership activities. These are not things where we have statutory authority to execute, but they've been identified by the advisory council and others as important for our model to succeed. So we are focused on care coordination and infrastructure, consumer engagement and outreach, and alignment models. And all of those activities are being done together with other state agencies, including MHCC and DHMH, and that's how we're organizing to take those activities forward. Just to give you a very high-level view, and at some point it may make sense to give you a more detailed view. I wanted to just walk through a strategic roadmap of what we're working on that was under that box 2 of year 2 implementation activities. In the first box here, we're focused on state-level infrastructure. This is infrastructure that was recommended by a care coordination work group that sat together for about 5 months. Ben Stephan participated with us in that process, and Laura Herrera and Carmela Coyle co-chaired that work group. And out of that, we are focused on the implementation of infrastructure, primarily at CRISP, that will allow for the sharing of meaningful and actionable data, things like care profiles, letting case managers get enhanced notifications, and coordinating some of the activities that are resulting from care coordination infrastructure implementation, as well as the culmination of investments in the state of, somewhere above $2 billion in electronic health records. And all of our providers are not connected to the HIE, so a big part of the effort also is to get all of the community-based providers in the long-term care facilities in Maryland connected to CRISP. And we are working with MHCC on that implementation plan now. The second area deals with alignment activities, and as I mentioned a few minutes ago, Medicare has some new chronic care codes. If we were able to successfully, if physicians were able to successfully execute the requirements to build those chronic care codes, it could bring over $100 million into primary care practices in the state for Medicare patients. So we think that's a very important activity to pursue because it aligns with the new model and focuses on the chronic care improvement that we really want to facilitate. We have met with CMS to begin discussing some gain sharing and pay for performance models and waivers for that. And as I mentioned a few minutes ago, the Medicaid is focused on the dual eligible, creating a dual eligible ACO, and we're focused on continuing discussions of how to create integrated care networks for patients who are not in other ACOs or in managed care. A point to note is that Medicare is really encouraging Maryland to accelerate demonstrations and evaluations of opportunities to move toward phase 2, and there will be increasing discussions about the potential to accelerate some demonstrations in the upcoming months. The third area relates to care coordination and integration, and we would call this the resources or the people element of the program, and this is really something that has to be regionally and locally led. It's a provider-driven activity. It will require very significant investments in ongoing costs, and the HSCRC is focused on providing some technical assistance to folks during this process, but really driving this from the provider side and not from the regulatory side. And we're also proposing, as part of our annual rate update, a 0.4% increase to help support this process. We just approved some planning grants for regional activities, and we also have proposed an adjustment of 0.25% effective January 1 for things that may be shovel-ready for implementation by January 1. And the last leg on this roadmap really is getting consumers engaged. There have been activities already underway with some public presentations and some focus on faith-based initiatives by one of our consumer work groups, and the other work group is completing some efforts relative to extending the engagement and outreach activities with consumers. We're especially interested in having them involved in the care coordination process and encouraging care coordination in the state. So I think, just to drive us to the finish line, the new waiver is really a call to action, and it really creates a very significant path for change. It's the most significant change to the Health Services Cost Review Commission in 40 years. And it demands a proactive and rather than a reactive process to get it implemented, and for providers to take a proactive approach in developing more flexible and creative investments to drive care delivery change. Medicare and other payers are focused on care coordination, and we think they're prepared to pay for it, as evidenced by the new Medicare chronic care fee, and it's something that needs to be driven into the process to deliver the value in the new model. The new model is highly dependent on partnerships across providers, settings, not just the hospital, but in order to avoid hospital utilization for things that are avoidable, there needs to be extensive partnerships across settings, and also with community-based organizations and consumers. And I think just one more thing, we've talked about potentially avoidable utilization a few times during the presentation, and just to give you the HSCRC staff's definition of potentially avoidable utilization, we know that there are lots of other avoidable utilization beyond these areas, but these are the areas that we're specifically focused on. We're focused on unplanned care that can be prevented through improved care coordination, and effective primary care, and improved population health. So we're focused on readmissions and rehospitalizations. The AHRQ definition of prevention quality indicators, so preventable admissions and ER visits that can be reduced with improved community care. We're very specifically focused on admissions from skilled nursing facilities and assisted living residents. Some of the reports are that as much as 70% of admissions from skilled nursing facilities could be avoided. We are also focused, as we have been in the past, on reducing healthcare acquired conditions. Lastly on the list is admissions and ER visits for high needs and chronic and complex patients that can be addressed with better care coordination. So, and I also just, for your information, attached some of the, a little detailing of some of the regional and local efforts that we would expect to come out of the regional planning processes and the hospital processes focused on care coordination and care improvement. And I think that's I wanted to leave time at the end to allow for questions and comments, and to hear your questions and to hear your input to what we're doing. So with that, I would like to open it up for questions.
Thank you.